Thank you for joining us for today's webinar, Prevention's Role in Addressing Adolescent Co-Occurring Conditions. My name is Marla Kaufman, and I'm the Senior Communication and Health Promotion Associate at IRETA. I'll be moderating our webinar today. I would like to go over some quick housekeeping items about how to use the WebEx technology and how to access continuing education credits. While I'm going through this information, there are a few poll questions being broadcasted right now if you would like to fill those out. First, we would like to encourage you to participate in today's webinar through a few ways. If you have questions for our presenter or are experiencing any technical difficulties, please use either the chat function or the Q&A panel to communicate your questions. Our presenter, Ken Winters, Ph.D., will be taking questions after the webinar. Feel free to submit your questions through the chat box or Q&A box at any time. This webinar is approved for 1 PCB and/or NADAC credits, which are free. A certificate of attendance will also be available to download from your MyIRETA account. Please note that it will take up to 48 hours for your CEUs and certificate to be available in your MyIRETA profile because we have to cross-check your attendance with WebEx following the webinar. After the webinar, you will receive a follow-up email. This email will include a link to an evaluation form for the webinar, as well as more information on how to access your certificate of attendance and continuing education credits. We may send you an additional email to remind you of the evaluation. I would now like to introduce today's presenter. Ken Winters, PhD, is a senior scientist at the Oregon Research Institute and a consultant for the Native Center for Behavioral Health at the University of Iowa. He previously was a professor at the University of Minnesota's Department of Psychiatry, where he founded and directed the Center for Adolescent Substance Abuse Research for 25 years. Dr. Winters has received numerous research grants to address adolescent behavioral health from the National Institute of Health and various foundations during a 35-year period. He has published over 200 peer-reviewed articles and other works. Okay, Dr. Winters, if you are ready, I will pass things over to you and close this poll.
Excellent. Marla, thank you. Hello, everyone. Pleasure to have this opportunity. The topic, is really about the intersection of prevention and co-occurring conditions. I can appreciate many of you are in the treatment field, but I hope that you will still see a lot of relevance to this. In many ways, when you're a counselor treating individuals, you're trying to prevent the escalation of the problem or prevent relapse. So even if you're not a prevention specialist and not someone who works with schools and implementing prevention programs, I think you'll still find this information of value. And there is plenty to talk about in the clinical arena. The whole concept of dual diagnosis or co-occurring and coexisting disorders really is rich in the clinical and treatment literature, not as much in the prevention arena. But I'll talk about some ways I think our views of prevention and what we know about best practices for prevention can be applied to addressing this whole issue of co-occurring problems and conditions. My email's on the first slide. Feel free to follow up with an email to me if I can't get to one of your questions. And if people want a copy of the slide deck, I will send it to Marla and she can pass it around.
Dr. Winters, those poll results should be showing as well if you wanted to take a look at those.
You know, Marla, how do I get the poll to show up again?
Oh, let me
I had it.
see
I
here.
put
All right, did it come up now?
no, I mean I put I blocked it out because I thought I was going to need to see most of my screen. So maybe that was my fate.
That's okay. Well, I can just sum up what I'm
Yeah,
seeing.
yeah.
So about 34% of folks said that they're counselors, social workers. 9% of folks said they were nurses, nurse practitioners, physicians, and then 17% said other. As far as fields, it looks like most people are coming to us from the addiction treatment field at 34%, and
Excellent.
then 20% are in the mental health field, 9% are in education, and 3% are in physical health or EAP. And for the question you asked about my profession, provides training on co-occurring disorders. 37% said true and 20% said false. 43% were not able to answer, but
Okay. All right. So for some, this might be a primer on the topic. Excellent. And feel free to put questions in the chat boxes, and Marla will help monitor those, and we'll do some sharing as best as possible. I want to leave time at the end for it, so I may go fast, but in the hopes that we get a chance to have discussion. I've organized the talk around these four themes. 1, 2, and 3 is the core of the presentation, with number 4 a summary. But there's several setting the stage topics I want to get to help us throughout. And there's a whole issue of definitions and terminologies. So briefly, the term co-occurring disorders is more the traditional term, and that has been viewed as the presence of one or more diagnosable disorders using the DSM-based system. And traditionally, that meant that there was a presence of a drug abuse problem. So my image to the right reflects kind of that older traditional viewpoint. There's a more contemporary definition, and people are now talking about co-occurring conditions, which is meant to be a more broad range of thinking about mental health problems and disorders. So I'll occasionally go back and forth with the term problems versus disorders. And the collection of such problems and disorders don't necessarily have to coexist with drug abuse. Common, yes, but not necessarily for the definition. So you can have people with depression, anxiety, and PTSD, but not a drug abuse problem, for example. And there's, of course, quite a rich growing treatment literature when that is the case, and the prevention field has realized that as well. So in that light, I want to distinguish problems from disorders. Problems would be at the low end of a severity continuum, where disorders would be at the high end, at the severity end of the spectrum. Thinking of teenagers, co-occurring problems would be things like school, mental health, legal issues, the presence of risk factors or absence of protective factors. If we think about disorders, all of that's at the more severe end of the severity spectrum, and there we're talking about DSM-defined disorders. The common ones you see in the literature with this co-occurring phenomenon are the internalizing and externalizing disorders. That's a couple ways of categorizing: internalizing depression, anxiety, PTSD; externalizing, substance use disorders, ADHD, conduct disorders, and even the psychoses. This phenomenon is complex. There's a lot of research and discussion on how they interact, how the interaction of co-occurring conditions can be a maintenance factor. They can exacerbate one or more conditions. And then there's a lot of literature on the role of a range of biopsychosocial determinants that can be garnered, that information can be garnered to use for developing prevention programs and treatment strategies. I'll get into a little bit of that later, but the complexity of it is such that you really don't necessarily have to know exactly what the basis or even the subtle nature or the complex nature of a given client's co-occurring problems to do a good job with addressing it. You'll see how I think the prevention field is trying to tackle that issue when I get to that in the talk. A couple more setting the stage topics. I just want to bring to bear some themes about youth and behavioral health. Um, I think, as we all know, adolescence is a vulnerable period for the onset of co-occurring conditions. Um, how they will play out is going to vary considerably. For some teenagers, you might really just view it as normal adolescence, the normal challenges of being a teenager. And these so-called issues, conditions, problems, they will fade with time. But for some teens, it's really a red flag that there are future serious problems and disorders not only emerging quite soon in the teen years, but perhaps emerging later in adulthood. For example, when you just look at now disorders, this nice summary by Lee in a science article in 2014 showed the extent to which adolescence is a peak time for the clinical onset of many disorders. You can see, for example, what's one of the earliest ones to emerge at the top of the list, ADHD. Go to the third row, depression. That is interesting because that shows a greater variability with perhaps the higher prevalence emerging a little bit later in youth. The bottom row shows a composite or a summary. So in one way, Lee is saying if you looked at across mental disorders, peak years right around 15. So adolescence, obviously a significant public health period. I thought I would just highlight a couple things about substance use disorders. And one of them I'm going to profile here is the role of early onset of cannabis use and then the risk of developing a cannabis use disorder within 1 year or within 3 years. And so the sets of bars demonstrate the big difference. I put in the red box the data that shows for those that initiate cannabis use during the adolescent years, you can see the probability of having a cannabis use disorder is about 11% within 1 month and about 20% if you look 3 years out or 36 months out. Then contrast the data to the right, which is those that waited until after adolescence to start using cannabis, and you can see quite a difference, roughly 2 times the probability of having, or 2 times the likelihood of cannabis use disorder if you start your initiation during the teen years, as opposed to waiting until young adulthood. Age of initiation of use also has a relationship with how long it takes you to reach abstinence. So now this is a clinical sample, not a general sample, and it's looking at the relationship between individuals and how they differed when they started their problem with substance use and then went to treatment, and then their path to recovery was described. The red line, the under 15 line, represents these are individuals that started using substance use age 15 or younger, and then you can see how that their path progress to achieve abstinence is much slower than the more favorable line, which is in blue. These are individuals who waited till 21 or older to start their substance use. And their path, their progress to recovery was much quicker, about 50% quicker. A couple indications that prevention works. One is if we look at to the extent to which young people these days are choosing to go through the teen years drug-free. Data analyzed by Sharon Levy and colleagues reported this in 2020. So I think the trend lines are still the same. The last time I looked, one could make a case that this is still the case. The blue line here is probably the most informative. There's two, I understand. This is just past month data, but the blue line is an indication of the percent of teens that said when they were in grade 12. So they're already seniors in high school and they're reporting on historical use. And the blue line represents the percent that said they haven't used any substances for their teen years, for lifetime. And so the 31% at the far right here would represent an indication. This is the so-called prevalence of drug-free teens. So somewhat encouraging because you can see the line, the trend is moving in the favorable direction. Another sign that prevention works, and this is if you look at outcome data, it's quite promising when we consider the extent to which prevention programs, even those that are primarily focusing on targeting substance use, also have a nice domino effect of addressing and improving co-occurring conditions. I'll show you a little bit of data on that coming up, but I wanted to give you a preview that a good, solid substance use prevention program also has some nice effects on these other factors, the risk, protective, co-occurring problems, etc. More on that soon. This topic can be summarized in many excellent publications. I have 4 of them here. The one to the left that I have in the largest size with the number 1 below it is the one I like the best. A publication by NIDA that not only summarized key features of good prevention, but listed some of the promising programs, but other publications by SAMHSA, and then to the far right, a handbook from edited by some scholars in the field. But I wanted just to profile the one I thought interesting finding from the NIDA's Red Book. And they summarized what they could come to believe are the keys to effective prevention. I've listed 8 of them here. If you read the full Red Book, you'll see that there's more than 8. So I've done a little summarizing and collapsing. But I wanted to profile for you that many of these effective principles also have relevance to when we want to address co-occurring problems and disorders in young people. Particularly look at number 2, 3, and 4. They all have to do with addressing risk and protective factors. And that theme is going to come up quite soon. Also number 6, where there's an effort in the community to address knowledge, attitudes, and beliefs. Also very important when you think of trying to address underlying co-occurring issues with young people. But we'll get more specific with how nice of an alignment there is with prevention programs and these effective principles. The Southwest PTTC produced a wonderful directory of registries of evidence-based prevention programs. So they identified the various, and there's several, registries. And so their guidebook provides a listing and a summary of all the various registries. Wonderful resource if you want to look a little deeper into what's out there. What do people say is evidence-based and evidence-informed? What are programs that work best for those young people in the juvenile justice field? What if it's just a general need for universal programs in schools? How about selective programs? We already have identification of high-risk kids, and you want to be a little bit more intensive with your program and content. This document does a great job of providing guidance for how to find some of those programs. Next up, I'm calling it looking under the hood of the topic of co-occurring conditions and adolescence. So remember now, co-occurring conditions can refer to either problems or disorders, and I'll try to distinguish those along the way here. But I have 5 that I want to introduce. And one of them just reminds us that being a teenager can be a source or can be an onset factor, an elicitor of co-occurring problems and disorders. So being a wonderful teenager in America these days and being a healthy, normal one can still, unfortunately, contribute to problems downstream. I have of 8 tendencies and features of adolescence, then some of these could be considered risk factors, but they're all normal. They're all things that are very common and healthy among teens. But when a teen has trouble controlling emotions, for example, number 5 there, or go down to number 8, take risk and show poor self-control. These are things that can cascade downstream and create problems for a young person and maybe even contribute to the onset of disorders. But it's important to keep in mind that being a normal teen is in some ways poses a public health challenge for that young person and parents and communities. Second principle, if we look at what are typical adolescent risk factors, they are often associated with multiple problems or co-occurring problems. So across the top in the red box, there are 6 problem domains that are listed here, all the way from substance abuse to depression and anxiety. And then Bob Blum, in this publication of 2015, looked at wide-ranging literature on risk factors. He broke them into these 4 categories, and then he made a determination to what extent is our understanding of these problem behaviors associated with these various risk factors. So he put a check mark where he said there was a hit or an alignment, and you can see that there's just an immense overlap. So I think it's fair to say, if I look across rows, every risk factor has a potential contributing role in at least 2 and often several of these problem domains. So when a program is addressing risk factors, even though they might be focused on a single domain across the top or problem behavior across the top, they probably are having a wonderful iatrogenic positive effect on multiple problem domains. So it's my repeat principle. A good substance abuse prevention program that does a great job of addressing risk factors probably is doing a job, even indirectly, of addressing other problem behaviors. A reminder of a principle my colleague Larry Shire likes to emphasize: as the number of risks accumulate, or what he calls a snowball effect, the greater the individual's overall risk of co-occurring problems. Another way of saying, to the extent you can reduce a teen's risk factors or increase their protective factors, you're reducing overall risk of a wide range of problems, not just necessarily the one that might be targeted in a given prevention program. All right. Next up is just a little attention on the intersection of substance use severity and co-occurring conditions. This one is looking at co-occurring problems as a function of young people who are grouped into these 4 groups: those that did not meet any diagnostic criteria for substance use disorder, and those that either met mild, moderate, or severe level of a DSM-based, DSM-5 based substance use disorder. And you can see the relationship of, to the extent they had either 0 or a lot of problems, is consistent with how we might expect it. The severe individuals, those in the severe group, you can see they had a lot more problems on average than those that didn't meet any substance use disorder criteria. Of course, the nature of these data is interactive and bidirectional. So if you use substances, you might create problems. You might have pre-existing problems, and that might lead you to use substances. And of course, those two things can interact and exacerbate each other. A related piece of data comes from a recent journal article published by Halliday and colleagues. They looked for longitudinal studies that explored the longitudinal relationship between substance use and mental health among young people. And they had a broad range there of 12 to 25. They had publications that both were from the community samples and clinical samples, but they were wanting to see to what kinds of co-occurring problems were common among those that use substances, and that these problems persisted over time. So they were trying to make a case that the substance use was a core causal factor in the translation to having particular problems. And I've summarized down there in red font what there were the three main problem domains that they identified. There was an internalizing factor, things like depression, anxiety, externalizing domain, conduct disorders, ADHD would fit there. And then there was a family related domain showing that parental substance abuse or mental illness in the home also had relationship. If you look in treatment samples, those that are seeking treatment for behavioral health problems, you see a strong association between having a substance use disorder and another psychiatric disorder. This is data summarized from a large database. And you can see that 61%, that's the rose-colored portion of the pie, they had both a substance use disorder and at least one other psychiatric disorder. And you can see the other slices are smaller. It was pretty rare to just have a substance use only disorder. That was 18%. There was a certain percent of the population that was getting treatment that didn't meet any diagnostic criteria. That's kind of an interesting question. To what extent was the rigor of the assessment that led them to get hospitalized? But the point is, it's more the rule than the exception to see co-occurring problems when you're starting out with a substance use disorder. Then there is a literature that's looked at what types of disorders seem to be more common when you start with a sample that has a diagnosis of at least one substance use problem, and then you look to see the pattern of other disorders. I'm summarizing here data from several publications, and you can see the range. It's big, depends on the various studies. A lot of internalizing and externalizing disorders. And then I have this as listed: bipolar, borderline, learning disorders, and eating disorders. I didn't put any percent on the chart because it's the data is so limited, it's hard to know if the findings are reliable. But you can see it's the externalizing and internalizing disorders do show up. Okay, briefly about underlying origins of co-occurring conditions. It does speak to the complexity of this phenomenon. My read of the literature is that there's been three major causal models discussed: dysregulation, vulnerability to stress, and self-medication. And the models are not mutually exclusive, so a person could be having an influence of more than one source or pathway. And as I mentioned earlier, they're interactive. They can be bidirectional. Briefly, with each of them, I'll just give a few sound bites. The dysregulation pathway, that suggests that a young person starts out with difficulties in impulse control and delaying gratification, and because of those personality traits, that leads to vulnerability to getting into trouble, making bad decisions, perhaps using drugs, but also engaging in all kinds of behaviors that likely add risk and minimize protection, and that creates downstream disorders. I've put in here just a snapshot of the marshmallow test. Maybe you know about that. If you go online and Google it, you can see how difficult it is for children to resist eating a marshmallow, even when they're told if they can just wait and hold off, they can get a lot more later. In the short video shows the wonderful frustration in the trying to proceed carefully with some resistance of temptation when faced with a wonderful marshmallow. But there are obviously more sophisticated tests for this, and you can see, though, early in life you get a temperament related to dysregulation that can persist. It can be trait-like, and unfortunately it can contribute to problems downstream. The vulnerability to stress model suggests that for whatever reason stress might be at play, whether it's biological based, environmental, or both, but with difficulty handling stress and not having a lot of resilience, the individual can cascade into negative emotions, making bad decisions. It might contribute to drug use, but surely might contribute to all kinds of problems related to the internalizing domain, particularly anxiety and depression. The self-medication model is directly related to the notion that there are some underlying risk factors in a person and they drift towards substance use to help address it. The notion that drug use can have psychological benefits, and the person is trying to deal with pre-existing underlying negative conditions and emotions and drifts towards the problem of substance use. Then the substance use perhaps aggravates the underlying condition, and the substance use continues because the person is starting to get addicted, and so then you get multiple problems downstream. One thing that shows up in the literature with all three of these models is the potential role of adverse childhood experiences or trauma. And you could apply all of them to all of the models to the potential for ACEs to aggravate the onset of co-occurring conditions. Particularly number 2, vulnerability to stress, and number 3, self-medication. You can imagine that if there's an ACE, that might create additional vulnerability to stress and create all kinds of problems. And ACE also could be a precursor to somebody self-medicating. Okay. So let's get to the third topic, which is, I think, hopefully the biggie for our discussion today, the relevance of all of this to prevention programs. So I'm going to start with the concept that model programs typically share various features. So if you read NIDA's Red Book, look at the literature, one could make a case that model prevention programs have 3 pillars. I've listed them here with some descriptors. Pillar number 1, where the program targets risk and protective factors, tries to reduce the risk and enhance the protective factors. And that can span individual, family, community, school, a lot of domains there, a lot of settings. A second pillar is the program enhancing prevention-related skills, things like improving decision-making. That'd be related to improving resisting impulses and delaying gratification, having coping skills in your toolbox to deal with stress and perhaps the early onset of addiction, and how to deal with peer influences. It's not a news bulletin to remind everyone that during the teen years, it's quite likely that that teen's peers has more of an influence on behaviors and attitudes than the parents. It's a very difficult time of parenting a young person where the parent realizes they maybe don't have as much of an opportunity to steer that teen in certain ways, as opposed to the peers. Always a big challenge. So a skill to help teens figure out, well, maybe some of that influence isn't going so well, is not so healthy. And they may realize that, but it can be difficult to resist, to go against the grain and not lose, how do you go against the grain and not lose face with your friends? All of that, works against perhaps good decision making in the throes of various social situations. And then the other pillar has to do with kind of the attitudes issues or values issues, knowledge, attitudes, and beliefs. I've bundled them together because they tend to show up as a threesome when you look at prevention programs. Examples would be altering normative perceptions. You may know about the phrase "the reign of error." That's where teens tend to overestimate how much so-called problem behaviors, including drug use, exist among their friends. And so by thinking it's quite common, that can tend to lead teens to engage in it because they don't want to be left out or don't want to be on the outside. But when you give them the data, they realize that they perhaps have misperceived things. And then there's all kinds of misperceptions about substance use, short-term, long-term harms, etc. That's coming into play pretty significantly with cannabis, as the country's going more cannabis oriented or more pro marijuana, I call it. And that's I think a lot of people are bringing some misperceptions along, including adults and policymakers, and that's likely also impacting young people's views of cannabis. Okay, so how would model programs stack up in trying to address co-occurring conditions if they have these three pillars? So consider a typical middle or high school in the US, and then assume that it implements a well-known model universal substance abuse prevention program. It strikes me that a model universal program would be highly relevant in addressing co-occurring conditions if they had the three pillars. And a selective program would perhaps even be more relevant to addressing co-occurring conditions, because selective programs rev up content and activities to really try to address known risk factors in individuals, and being quite intentful in addressing them. So let's look at the three pillars a little more detail. I'm making a case that if they have the three pillars, they are set up to do a nice job of addressing co-occurring conditions. And that could be problems and disorders. So I'm even making a case that it's across the spectrum. But I've targeted in red the risk and protective factors concept for the moment. Well, let's go back to what we showed as Bob Blum's data. So by addressing risk and protective factors, look at all the problem domains that you are probably going to have some wonderful positive impacts upon. And so even if it's just a program that's looking at delinquency or substance use, as I mentioned earlier, there might be some wonderful secondary effects across the board. So let's go to number 2 and 3, those pillars. Enhancing prevention-related skills. Well, if you're going to have a great program that's doing a good job with teaching decision-making skills, coping skills, how to address peer influences, that can have wonderful effects, not only on hopefully pulling back on substance use or deciding not to use at all, but surely can help with other problems that a teen might be having: depression, anxiety, dealing with delinquency. Better decision making can help you figure out how to cope with, how to deal with the blues, how to have particular short-term or long-term skills to deal with anxiety. The sources could be at school, with friends, at home. So the teenager improving their coping toolbox for a wide range of problems is going to be a benefit, even if it's not looking directly at the substance use topic. And then addressing knowledge, attitudes, and beliefs. So that is really a pillar that is often, at least with typical substance use prevention programs, addressing specific topics of knowledge, attitudes, and beliefs related to drug use. But if a teenager can pull back on either their current use or not engage in use, that's likely going to have wonderful effects downstream on co-occurring either problems or disorders, because it's likely that no co-occurring problem or disorder gets better if you're using substances. I'm not sure of any teenage problem that gets better by using alcohol or cannabis, for example. So at least it's likely going to set the stage for a teenager to have a little easier job, or will likely promote a healthy pathway. If there's not use of substances and a program that's addressing knowledge, attitudes, and beliefs, likely is going to help in that direction. Okay, so the third thing I decided to do with this topic is, so how good are model programs with alignment with the pillars? So over the years, when I've just generally known about programs, it struck me, well, they're pretty good at it. And if you read NIDA's Red Book and some of the other resources I showed, they mentioned that, they're quite strong in the following ways. But there was an opportunity for me to get into this topic with a little more detail by capitalizing on a project out of UCLA called the Super Project. And researchers there at UCLA are developing a wonderful guidebook on best practices and evidence-informed prevention. But I had the opportunity to look at some of the material because I'm a consultant with the project. And what they've done is they started by identifying a set of well-known evidence-informed or evidence-based prevention programs. And they came up with a list of 34. So then they looked deeply into the 34 to determine the quality of their outcome research. So, how good was the program in proving that it addressed substance use issues, reducing use, delaying onset, that kind of thing. And 23 of the 34, or 78%, they rated as the best. And they gave kind of more detailed descriptions about the evidence. But anyways, so 23 really were blue chippers. So I went to those 23 and wanted to see, well, how well are they aligned with the pillars? 100% of the 23 had content and activities that addressed risk and protective factors. 100% provided skill building content, and about 75% addressed the knowledge, attitudes, and beliefs. Examples, I put 3 over here: communities of care, life skills training, and strengthening families. But just wanted to note that there are some perhaps prevention programs you're familiar with were among the 23. I went one step further. So I did a brief assessment of these 3. Didn't have time to do more. That'd be quite arduous. But I took the 3 and focused on pillar 1, the risk and protective factors. I think one of the most important pillars if we're looking at how does the prevention program address co-occurring issues. And so the communities that care, that actually has content and activities that address 40 factors. Some of them protective, some of them risk. Life skills has 16, again, a mix of risk and protective, and strengthening the families has 8. So if you read across the rows, you will see my assessment, my rating of how strong the evidence was for that particular prevention program to effectively address factors. And so there are three factors, domains: individual, family, and school, that I could distill from these programs. And then I went to the articles that showed outcome relating to these factors, and I came up with this check mark rating system. So if there's a double check mark, that meant the evidence was quite strong. If there's a single check mark, it was promising, but wasn't a lot of detail, but at least it showed it didn't make things worse. So you can see each of the programs, Communities of Care, Life Skills, and Strength and Family, they had at least one domain of factors that they did quite well in improving. So Communities of Care, you can see my judgment was that program does an excellent job of addressing external behaviors, things like drug use and conduct disorders, etc. So their factors were doing a good job of helping with this domain. Life Skills, they had factors that were looking to improve both the externalizing behaviors and coping behaviors. Excellent job with that. And Strengthening the Family had content and activities revolving around family risk and protective factors, and they were showing nice results for parental influences. Not too surprising, it's a family-based program. But my takeaway from this was, if you look at programs and you try to dig deeply, you can see that they're addressing important risk factors and protective factors, reducing risk, enhancing protection. And these have nice results when you look at outcomes for important behaviors above and beyond just substance use. Now, all of these were excellent by the UCLA group in reducing substance use or delaying onset of use. So they were excellent in that range. But my thought was, well, how well are they doing with maybe some co-occurring issues? And so this was encouraging to me. Okay. A couple more. Oops, let me get to a couple more factors to talk about, and then I'll summarize, because I see we're getting down to 15 minutes to go. There is an interesting trend that's emerging in the prevention field. It's also happening in the treatment field, but this is the idea of personalizing approaches based on various factors in the intended target. So for prevention, one approach has been, so how could prevention curriculum, the content of prevention, the focus of the prevention, be altered based on personality types that are in a given large population of students? And Conrad at McGill University, she has looked at this by thinking that personality type of a teenager is best matched to the prevention curriculum, and you might get better outcome than if you don't match that teenager's particular personality type to a tailored prevention approach. And so she has researched this by looking at the use of a personality test or questionnaire that allows her to categorize young people based on, to what extent, which of 4 possible personality profiles are more prevalent in the teenager. So it's basically saying if the teenager takes a personality test that has items related to these 4 domains, which is the one that has the high watermark for that given teen. And then she will group teenagers with similar high watermarks into a tailored prevention program and looks at outcome compared to teens that didn't get any match. So example, teen that showed a little bit more severity, a higher score on anxiety sensitivity scale within that questionnaire, they get program and content related to how to deal with anxiety issues, coping with stresses, triggers, etc. So you can see there's a ways to tailor your content and activities based on these distinct different personality types. And she found that the matched philosophy worked better than if there was no match. So that is something that people are looking at in prevention the treatment field is also starting to get sophisticated with that, not just with how you might tailor cognitive behavior therapy, but how you might tailor use of psychosocial plus or minus medication, for example. Then there is the last I want to bring to bear to our discussion. And this, whoops, too fast. This is the notion that there may be some important principles of prevention when we talk about expanding our view of prevention in trying to address co-occurring conditions. So I started with a document being produced by a group in Oregon that's looking at how to develop principles for treatment service providers who are most likely dealing with co-occurring disorders in their clients. And these are the 6 basic principles: welcome and engage those with co-occurring conditions, adopt a positive hope-oriented approach, assume a developmental approach, demonstrate social and cultural awareness, assess and address immediate and urgent health needs, and build and connect and collaborate with caring professionals and support providers. So I looked at these 6 treatment service provider principles that are intended for those that want to improve their competency with dealing with co-occurring disorders, and I adjusted it for prevention. And so in red are the replaced in new terms, but through a lens of prevention. So I'm making a case that one could talk about important principles for those in the workforce that are trying to advance prevention, whether it's primary prevention, secondary or tertiary. And these principles can match nicely with the principles that people in the treatment field likely would benefit from. And so acknowledge that many youth have co-occurring conditions, adopt a positive, hope-oriented, strength-based culture of prevention, assume a developmental lifespan approach with prevention curriculum, demonstrate social and cultural awareness and responsiveness with prevention implementation, acknowledge that some youth may have urgent health and safety risk and vulnerabilities, build, connect, and collaborate with caring parents and community supporters. So there's a parallel, I think, and I think that the wonderful folks at Oregon are providing a base from which we can extend their concepts to the prevention world. My summary, I got just some brief summary points, not a news bulletin. Co-occurring conditions, whether they're problems or disorders, they are common among adolescents, and they're common among normal adolescents as well as those that meet clinical definitions of disorders and need treatment. There are 3 prominent causal models. All of them have support. I'd make a case that good evidence-informed, evidence-based prevention approaches can be effective in addressing co-occurring conditions. I think that the 3 prevention pillars align well with targeting the range of problems and disorders that fit our notion of coexisting issues among young people. Even if one is focusing on substance use prevention, it strikes me that they're doing a wonderful job also of helping with and being sensitive to the wider range of problems that many teens have. So in reality, we are all behavioral health prevention specialists, whether we're in the treatment field or the prevention field. And while we might have gotten our formal training in mental health or addiction, you probably have realized that it's really a behavioral health arena that we work in, and not just one with the silos of mental health or substance abuse. Okay, thank you for this opportunity. There's plenty of time if people want to share some thoughts and ideas or get into a discussion.
so much, Ken. We do have a few questions that came in. So Tracy asked, do you find that youth, especially with teen groups who lack an identity, don't understand their history or cultural backgrounds and traditions, or are not well connected to their communities, have a greater risk factor for co-occurring issues and problems?
That's an interesting point. That would surely fit into, the category of risk factors that are in the range of psychosocial determinants. Um, I know one great example is Native American youth. So there's a lot of interesting studies that have shown for prevention, Native American youth that have a stronger cultural affinity um, have less risk for problem behaviors. And also on the treatment side, treatments that do a good job of enriching and perhaps re-identifying the cultural value and connectedness of Native Americans to their ancestry and their history do a better job in recovery. So I think it's both a risk factor or a protective factor. One of many, of course. It's that whole biopsychosocial factor story is complicated. It's biology, it's environment, it's community, all kinds of factors, isn't it? Sources of factors.
Great. Thanks for that answer. Someone asked if there's a link for or a place to find the super projects findings.
Great question. I will keep Marla updated on it. They're in progress. And I got access to because I was one of the consultants to help review some of the programs. So, but it's about soon to be distributed or published. Let me put it that way. So I'll let Marla know, and we can get the word out to folks.
Awesome.
I actually don't know what. That's a good question. If you Google UCLA Super, all caps, oh, it probably doesn't matter, project, I'm not sure what access you get. I got an internal access because they allowed me to look at the program details, et cetera, because I was rating them. I don't know what would happen if you tried it, but that would give you a peek about, well, how far along they are to getting it out in the public.
Great. Dr. Cohen asked, what measurements of client outcomes would you recommend to a local or state-sponsored and funded program to measure, especially if it has limited resources and budget?
Um, you might want to email me because I could send you some examples, but there are a lot of, I call them community-friendly resource assessment tools. Uh, One question I'd have for you is, does the audience and the funder want to know just about the substance use outcomes? Do they want to know about other outcomes, psychosocial outcomes? Do they want to know about process outcome, which is okay, how much involvement, engagement was there in the intended audience, or do they want to know about behavior? So all of those domains have, real straightforward assessment options, and then there's Cadillac versions of everything as well. Feel free to email me, and I can send you some examples
Great.
and some resources to go to. There's a lot written on it.
Therese asked, what are some preventative treatments for teens with anxiety?
Well, I'm a big fan of CBT. There's a lot of good models out there. Cognitive behavior therapy approaches with a good understanding of use of motivational interviewing are excellent for anxiety. Because you get at regardless of the source of someone's anxiety, if you can help them with their cognitions, their perceptions and attitudes about what's causing the anxiety or what's perhaps blocking their progress to deal with it, as well as certain behaviors that not only create more anxiety but prevent the abatement of anxiety. If you can do both, the cognitions and the behaviors, that's a wonderful recipe for success. Now, for some individuals, it's all cognitions and sometimes it's all behaviors, but that doesn't matter. I don't think. You don't have to, I don't think, overanalyze somebody's um, causes or etiologies of their anxiety. But when you can do the two-pronged approach, I think you maximize success. I'm also, in favor of getting a good evaluation for potential medication. Some of the anti-anxiety meds can be helpful for teens, but it's hard to find a good adolescent psychiatrist that can do a good job of assessing and making the proper medication decision. So got to be careful on that.
Cindy said, great info should be shared with parents that may have had prior SUD challenges as they raise their own kids. So,
And parents are key, aren't they?
mhm.
Even when it's parenting a teen, when you don't think they're having much influence. Many parents learn this later when their teens grow up,
Mm.
and the research suggests it too. But teens do appreciate, even in the middle of the adolescent years, when a parent's trying their best to support and be a good ally to the teen, even though they might not show it. But often teens reflect that, yeah, that was important to me. I needed that as a safety net, even though they might not have shown appreciation.
Mm.
I tell parents, just hang in there.
All right, one more question just came in, and then that will be the last one we take since it is one. Ahmed asked, what is the best assessment questionnaire or tool to assess adolescent in rural communities before conducting a presentation program?
So there are a lot of good ones, and feel free to email me. I can give you a list. But I love the GAIN, Global Ascertainment Individual Needs tool. Then there's a short version and a long version. So the GAIN SS and the GAIN regular. If you Google GAIN, GAIN assessment, you'll go to their website. You can see a wonderful description of all the tools, how to access. Some of them are very inexpensive. Um, some of them don't need training. That's a good start. Yeah,
I just put
excellent.
the link for that in
Thank
the
you, Marla.
chat. So if anybody is interested in that, that link is in there.
Did-
All right.
Feel free to put my email in there. Maybe you did.
Uh, what is
It's
it again? I'm sorry.
no problem. WINTE 001
Yes, at
at
Gmail.
umn.edu.
umn.edu. All right. All right. Well, thank you so much, Dr. Winters. This has been a great webinar. Getting lots of comments thanking you. And as he said, if anyone has other questions, please feel free to send him an email. I'm going to go over some last minute housekeeping items before we sign off here. So just thank you to everyone again for joining us, taking time out of your day. Thank you, Dr. Winters, for the presentation. I'd like to remind everyone that we will be receiving a PDF of today's PowerPoint along with the recording for today's presentation will be uploaded to our webinar library located on iRetta's website sometime in the near future. I now want to remind you of our evaluation and CEU process. You will receive several follow-up emails from us. The first email will include a link to the evaluation as well as step-by-step instructions on how to obtain CEUs. Please note that it will take up to 48 hours for your CEUs to become available because we have to cross-check attendance records. We would like to request that you fill out our evaluation. It should take no more than 2 minutes of your time. Again, we want to thank everyone for taking time out of your day to participate. If you have any questions at all, please email us. The email for iRetta is info@iretta.org, and I can be reached directly at marla@iretta.org. And with that, I will conclude today's webinar.
I want to thank Marla. She did a great job in helping along in producing this. Thanks, Marla.
Thanks so much. Thanks, Dr. Winters. Thanks, everyone. Have a great rest of your day.